I'm not sure if you can hear me yet. We're getting YouTube going. Okay. Oh, great. Okay, so let's go back to Zoom. Hi, everybody. We're just, for those people, I'm connecting this to YouTube as well. So just know this is going because I have no idea how many people are going to come, and I only have room for 1,000. I think we'll be okay, but just in case more come, I wanted it to go to YouTube as well. So anyway, so so yes, so just know that if you don't want to show your video on YouTube or whatever, but everybody looks good, so it's all good. And we'll sort right at 4, but so if you want to chat, just know this is going. I actually, oh, let's see, it's not recorded yet actually, but it is on YouTube. So I will hit record in a little bit, but it is on YouTube. And if it, so just say what you want to say. But hi, how's everybody doing?
Hey,
Good,
yeah.
good. Yeah, I'm so excited. I love when Dr. Millman joins us because she is just such a wealth of information. And if you haven't noticed, for those who've been with me, I'm back in my office. Yay! It's my, for those who didn't know, I had a minor flood in my house. So for a month, I was out of my office using like the fake background, which I really didn't like very much. But this is the real deal now. And it's completely decluttered. There is not one in here, which is like amazing, the most amazing feeling, not one extra piece of paper, one extra book.
That's great.
Yeah, so put in the chat where everybody's from. I see we already have Carolyn here from Israel, and I love to see. Hi. Yeah, it's not too late for you, not too early, but not too late.
Well, 11 o'clock at night.
Yeah, it is pretty late.
Yeah,
Yeah, Dr.
not too bad.
Dr. Millman's on the west. Yeah, it's past my bedtime. I try to go to bed at 10. Dr. Millman's on the West Coast, so that's why this is 1 o'clock for her, 4 o'clock for me. Let's see. Let's see where everybody's from. We have, let's see, New York, okay, South Carolina. I mean, well, it's nice here in New Jersey, London, Naples, Florida, Wisconsin. Okay, Canada. Amherst, I love Amherst, Massachusetts. It's so beautiful up there. Richmond, Virginia, San Francisco. Okay. That's last all over the place here, but we have the sun today, which is just so incredible.
Okay.
I was at a meeting all weekend in New York City in a hotel, and so I literally didn't see daylight. And so the sun this morning, I just said, "All right, I have to get out, get that morning sun," and it really like changed my whole day. I'm in like the best mood ever. San Jose, Las Vegas, Texas. Okay, we're really wide. Oh, and there's Dr. Millman. We're both wearing pink, like almost the same color. Oh my goodness, how funny is that? That's funny because you're usually in blue, and and I was just in the pink mood today. But this is like almost identical. Oh my gosh.
I'm in a sweater because it's cold here.
Oh, I'm in a sweater too, but it's been freezing here, but not as cold today, but sunny. The sun's,
Oh, yeah, I should really tell you what cold means. I think it's probably 55.
yeah, no, no, no. That is like boiling hot for what we right? We have Canadians here. We have Massachusetts. So
Have no
yeah,
sound.
55, right? Everybody is not
Oh,
cold.
no, it's
They also have
65.
no sound.
Oh,
Not bad.
okay. No,
It's
no,
cold.
no. Oh, that's so funny. Let's see. So Dr. Millman, we are on
Air
YouTube.
audio?
I connected it till YouTube. So
Oh, it's
hi, everybody
unmuted.
on YouTube as well. And we're going to start in 2 minutes because we're very on time people, right, Dr. Millman? And
Absolutely.
we're going to
Absolutely.
answer as many
I didn't
questions
know what to
as
do, so I
possible.
thought, well, okay, done
We'll
soon.
mute all of you in a minute, but but not yet because we're going to do my favorite way to start the show.
I would just leave and come back in and try.
Okay. Anyway, so everyone's writing in the chat. Let's see what else we have. We have Miss have Montana. We have
You want to go see your dad? Go see your dad. Go see your dad.
Dr. Millman has the cutest cat ever.
Go see it. Go see it.
Vermont,
Go
Manhattan
see
Beach.
it.
Love it. And I'm in New Jersey, Morristown, New Jersey. Which is
She got a bath.
She got a
My,
Oh, okay.
my kitty got a bath on Saturday.
Dr. Millman is the cutest kitty. Adorable. How
Well,
old is the kitty now?
she's 6 months. We'll see if she can make an appearance.
Oh, maybe she will.
Yeah,
Okay.
she
Really,
she
really
she
cute.
really might be too busy, but
Okay, so before we get started, what we're gonna do, I'm gonna introduce the class with Dr. Millman, but then I have a little ritual who the people who are in my programs know. We get our good energy going. So we'll talk about that. So you don't have to mute yet. After I will mute you also, but just we're gonna say hi, good energy, but I'll explain in a minute. But anyway, and if you're watching on YouTube or you're just watching, do it also because it gets you in the flow of everything. So let's see, we'll give it one more minute. Let's see what other colors people are wearing. I see some more pinks. Let's see. Kimberly's in a pretty pink and Carolyn's sort of orange pink. And then Anna's in a good hat, and that's a pretty color too. Oh my, look at Paula. That's like a very cool orange. We have
Yep,
more.
my baseball team color, San Francisco Giants.
Woohoo!
It's you just sometimes feel the color. Like I sometimes, and this is so bizarre. It's weird that a lot of times when I do a podcast, I'll just feel a color and the guest is like in the same color. It's sort of, or you just get in the mood for certain colors. Okay, it's 4 o'clock. So here's what I'm going to do. I'm going to pin you, Dr. Millman. I'm going to pin me. On a second. Pin you. Let me get myself pinned. And we're going to record so we don't miss anything. Okay, and then okay, but you don't have to mute yet. Oh, I just can't go over that. We're both in pink. I love it. All right, so here's what I'm going to do. Record.
So
Okay.
weird.
Okay, so hang on.
This meeting is being recorded.
Welcome everybody to Bone Health Q&A.
I should get my iPad.
Okay, nobody speak here for a second. We're going to start again. Welcome everybody to the Bone Health Q&A with Dr. Kim Millman. I'm just so excited that you've joined us here, Dr. Millman. And before I just want to just say a few words. Dr. Millman is a Stanford UCSF USC integrative physician, and she's also a research scientist. But the best part to me is that you've been working with osteoporosis and bone health in an integrative way for over 15 years and has really seen remarkable results. And this is what you bring to the table, and you have private practice, and you also have an amazing course that I'm so glad that I'm part of, and we'll talk about that later. But anyway, I just want to welcome you and thank you for taking the time out of your busy schedule to be here and help answer people's questions.
yeah, my pleasure. It's one of the funnest things that I get to do, and I love seeing all these fabulous faces here who want to be proactive about their bone health, and it's my favorite thing to talk about. And I just want to warn people, medications are not my forte. I was just seeing something in the chat about Tiblos that I'm probably not your go-to person for medications, but everything else,
Yeah. If you have medication questions, write them in the chat and just because we're gonna actually call on people. So we're not really gonna go through the chat. We're gonna, raise your hand if you want to ask a question. We'll call on you. And ideally, it's nice when you show your video, you don't have to, but that's how we're going to work it today. We just find it's more personal. We can see the person that's asking the question and we sort of have more fun that way. But if you have a medical question like that, I'm going to be interviewing Dr. Keith McCormick, that's like his forte. And so put those in because I'm thinking of having him on the podcast and I can ask those questions to him. So we'll save those for Dr. McCormick. And anyway, all right, so how I like to start the session is I'm going to put a different view back so we can see everybody. And I'm going to do that right now. I'm just going to change the view for a minute so we can see everybody. Okay, this is what I love. And wow, we have lots of people here. This is great. And so what I want you to do is put an intention out that you're gonna get something great from today, whether it's your question or half the time it's not even your question, it's someone else's question that oh wow, that's so interesting. But I know that everyone is going to get something from today's something from today's talk. So what I want you to do is just put an intention out there that you're going to receive something good from today. And what I want you to do on the count of three, we're going to think about the light coming in, all these positive, good vibes and good energy. And we're just going to, on the count of three, say, hi, good energy. And it juices me up. I'm really going to juice up Dr. Millman here. So get ready, Dr. Millman. Okay, so ready on the key. So unmute on the count of three. One,
Yay!
two, three. Hi, good
Hi.
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 Good energy. Woo.
Woo!
Hi, good
Yay.
energy.
Good
Okay, so
energy.
I'm going to mute everybody now. Now that we
Good
got
energy.
okay.
Awesome.
Yeah. So let me mute everybody here, except Dr. Millman, let me make you. Wait, let me find you here. Let me make you co-host. Would that be helpful? So that
Yes.
if you want to do anything, you have that authority. And let me just mute everybody but you. Okay, mute all. I don't want to mute you. You might be muted, Dr. Millman. Asked to unmute. Okay. Unmute yourself and then we're good. So what I'm going to do, I'm going to call on like one person at a time and I'll bring you up and then as I call on you, you can unmute. Okay? How does that sound?
And let's tell people a couple of things. So
Oh, yes.
so
Yes.
in order to raise your hand, you go under the React tab, which is on the bottom of the Zoom area, and then you can see raise hand, and go ahead and raise your hand if you have a question, and we'll take them in order. And the other thing is that I cannot give medical advice in this Q&A, so I may have to coach you a little bit about how to do the questions. So if I do that, don't take offense to it. It's just that it jeopardizes my license to actually answer very specific medical questions. So for example, like if somebody has a CTX and it's 450 or it's like 420, you might say, Dr. Millman, if you had someone in your practice who had a CTX in the low 400s and blah, 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 what would you do? What would be the kind of thing that you would be thinking of, or whatever your question is? Try to make it general. And I may have to coach you. For sure, don't talk about this is my lab. I'm 75. My rheumatologist says this, my endocrinologist says this. None of that is really all that relevant. Just kind of ask the question that you want to know in a general way. And then I can do the best I can in giving you an answer that will be helpful and thoughtful.
Okay, and I have one more thing to say. Get to the point sort of quickly, because sometimes people are, well, I have this and I have this. So we have a lot of people. We want to get to as many as possible. We're going to have an absolute, am I right, Dr. Millman? We'll stay, but by 2 hours, it's an absolute dead stop. So we'll try to answer as many questions as possible. And I just want to say one other thing, and we'll tell you about it later, but Dr. Millman is starting a course. And one of the reasons, so there are two reasons I wanted her to come here. One was that so many people have questions after the summit, and I can answer a lot of them, but it's always wonderful to have an expert like Dr. Millman, help to answer questions. And that's my goal, is to just really try to share as much knowledge as possible. But the second reason was, if you might be interested in this, you'll get a feel of what it's like, because this is what she does on every class. She helps answer questions, so you'll get a feel of what it feels like. And I'm big into vibes, that you have to resonate with the practitioner if you want to get involved with them. And that's why I thought it would also be a good way for people to get to know you who don't. Okay, so on that note, we are going to change the view so I can see everybody, but then I'll change the view. Okay, so Paula, you are first. Let me okay, I'll get rid of myself. Okay, Paula, you're on.
Okay, thanks. Dr. Millman, I have two questions if you could.
Oh, Paula, we would like to keep things to one question per person, and we will come back around if we have time, but we only want to do one question per person.
Okay. Um, when we go to UCSF Medical Center in San Francisco for DEXAs, we go for a bilateral DEXA that our doctor has ordered. UCF radiologists are telling the technicians not to do bilaterals because they are not medically necessary. We're trying to figure out, can UCSF refuse to provide bilateral DEXAs after the doctor has decided it's medically necessary and ordered it? I've asked a radiologist at UCSF about this, and he says the professional standard is to do a unilateral, and because bilaterals are so rare, it takes them longer to do the reports to figure out actually that it's a bilateral and analyze them separately. And sometimes they make mistakes in doing that. And now it's not I've been able to convince them to do a bilateral sometimes, but other times with my friends, they won't. And so we're just trying to figure out, do they have the right to refuse the doctor's order for a bilateral DEXA? If you know.
Yeah, I guess I don't know the answer to that question, except that what they may be saying is that your doctor may order a bilateral, and insurance won't be, if it's not medically necessary, then insurance won't pay for a bilateral. So maybe that's what they're getting at, and
Insurance pays, Medicare and our supplemental pays. They don't think it's medically necessary because that's not the standard of whatever association the radiologists belong to that set the standard of care.
I would say that I would think that a person's only recourse would be that their doctor would need to send some paragraph about why they believe that a bilateral is medically necessary in order for them to change their mind. I mean, it might be, there's many times, right? When, I mean, not right now, I'm fighting with an insurance company to get a patient Evenity where they want to give her Fosamax. And I'm saying, but Fosamax is not good enough. And they're saying, well, she needs to try the Fosamax first. And I'm like, no, she doesn't, right? But I'm fighting with the insurance company. But it may be a similar situation where the doctor has to intervene and say, why? But we do have to fight for our patients. So I'm not saying, so I don't think it's true that they can't deny a doctor's order, but that if they have a conversation with the doctor, then maybe the doctor can convince them that it is necessary.
Yeah. Okay. Once I've had it done, then it's easier to convince them to repeat it. But for people who haven't had the bilateral done, it's harder. So, okay, thank you. That's a good idea.
Okay, Margie. Maybe I see Liz as being the next one. Do you, Margie?
Okay, I unmuted. Thank you. Okay, so
I muted myself. Sorry. All right, Liz,
I'm in the state of New Jersey, and I'm wondering if there's a test that I should take, or somebody in the situation where they started HRT 4 months ago, and they've noticed like GI issues since they started that they didn't have before. Would the GI map help to determine if there's an issue metabolizing the hormones? And it's through creams and a progesterone pill. So would you recommend, or is there any recommended way to test if
Yeah,
that's causing it?
So I think that I always listen to my patients, right? So if my patient says nothing else has changed but the BHRT, and all of a sudden I have GI distress, then I'm going to find that highly suspicious that the BHRT is the cause. The creams tend to go through, they're getting absorbed through the skin. So they're not going through the liver and that's what's called first pass metabolism, but
Mhm.
the oral progesterone does.
Mhm.
So I would be suspicious of the oral progesterone, and and if you're getting progesterone from, if someone is getting progesterone from, say, Walgreens or CVS, they're a little soft gel and they're usually in some kind of a vegetable oil that is not that great for the body. And so most of the time, what I'm doing is that I am recommending, I'm hearing a feedback.
Yeah, me too. I'll mute myself.
So I'm recommending, uh-oh, it's a lot of feedback. Margie, you want to mute everybody but me? Or mute everybody and then I'll come back on? Great.
Everyone's
Oh,
muted. I'm just going to mute myself again. Try it now. I think it's
it's gone. It's gone. So, many times what I'm doing is I'm prescribing a compounding progesterone that's oral that is just microcellulose and the progesterone. So I get around that whole thing about the safflower oils and the sunflower oils, and sometimes corn can be there. And so my first thought would be to make that change, and see if that's the case. If a patient of mine was already on a compounding formulation, which would
yeah.
include just microcellulose, it's called E4M. If that was the situation, then I probably would. A GI map is a great test, but I don't know that it's really going to reveal why there is a change with the BHRT, but yet may reveal that the person has some dysbiosis, or maybe a lack of digestive enzymes sufficiency, that there is fat malabsorption or something like that. It might reveal that. I may think about doing something. It also depends on what the actual GI distress is for that person. That might give me another avenue as to maybe is there something that I can combat it. But I would think that first pass metabolism with the progesterone is potentially causing it. Is also, I think you mentioned that BHRT was started about 4 months ago. It seems like that's enough time to kind of, get your body adjusted to it. So, yeah, I think that the experimentation with the BHRT, it's kind of a tough thing, because you can't, a person can't do the estradiol without the progesterone and be safe. So one thing that could happen would be, and absolutely the person has to be looking at what is new. And if it's not just the BHRT, you can't blame the BHRT. Then you have to say to yourself, okay, well, progesterone can be done by itself. So you could take the estradiol, person could take the estradiol out of the equation and just do the progesterone by itself. If the GI distress remains, then it's likely the progesterone. And then something has to be done about the progesterone, or the gut health has to be evaluated. That's what I would say.
All right. Thank you.
I think Heather's next.
Hello,
Uh,
Dr.
Hi, Heather.
Hi.
Heather. Okay, I'm just trying to see where Heather is. Is Heather, are you?
I'm not on camera, but
Oh, okay, Heather. Okay, got it.
I have a question about testing for intestinal permeability. So GI map tests zonulin, as does the wheat zoomer. And if they're both low, but the wheat zoomer says anti-zonulin and anti-actin are high, how do you interpret that?
Yeah, so zonulin is the molecule that is the tight junction regulator. It's a large molecule. It comes and sits in the receptors, and when it sits in the receptors, then the tight junctions get leaky and they get permeable. And then, so when the zonulin is low, still is not as it's not as conclusive as the antibodies to LPS that you get in the blood, right? Because okay, so what is happening? Zonulin is coming and docking in the receptors. The zonulin can translocate across the gut membrane or move paracellularly, move in between the cells from the lumen of the gut, and they go to the interface between the other part of the gut cell and the blood, which is the immune system.
Mhm.
Immune system sees zonulin, and antibodies to zonulin increase. And when antibodies to zonulin increase, then you know there has been translocation, because that's the only way that those antibodies would have been generated in the gut. Um, Antibodies to LPS are the same way. The only way the LPS is going to get across is for that gut to be leaky. The only way that actin is part of the tight junctions, the only way antibodies to actin will get into the blood is for that gut cell to be leaky. So when the intestinal permeability panel in the food zoomers from Vibrant America is
Mhm.
my go-to. That's like, that is direct evidence that there's a leaky gut.
Okay, so that's just a lot more specific, and they're testing more things, and it's
And it's in the blood, right? It's
yeah,
in the
yeah,
blood. So there's no way that those antibodies get in the blood unless they've gone across the gut membrane.
right. Okay, thank you. That's very helpful.
Yeah, you're welcome. I see Basamath.
Yes,
Basamath.
hi.
Hi. Hi.
Okay, so I have had total knee replacement in the right leg from bone because I had bone spurs, I had a torn meniscus, I have some arthritis, and I'm very happy with the replacement. Now the left knee is starting to give me little indications of something. So I was given an X-ray and it was determined I had some arthritis, but not to the level that I had in the right knee. So now I'm wondering, at this time it wasn't that bad. So I didn't ask the orthopedic what he thought about platelet replacement, but now I'm thinking about what about platelet replacement? Would I better be a candidate for that? Or what could I do? I've been doing some exercises on my own. Occasionally it feels better and then it goes back to feeling the way it was. And I'm very concerned because I'm trying to avoid another surgery, of course.
Okay, let me intervene. So I'm going to coach you a little bit. So there were a lot of eyes and there were a lot of this and a lot of that. So a more general question would be, do you have any tricks or things that any supplements that might be able to be used in a osteoarthritis of the knee? And what do you think about PRP? So I do like PRP, and I think that it's a good second step. I think first step is always physical therapy, and I'm sure that Margie would agree with me. And there are also some things that you can do for osteoarthritis, things like glucosamine sulfate, things like a chondroitin sulfate. I will always recommend that. And then there's a peptide called BPC 157. You can take that orally, and it does help to heal the gut and helps to heal other tissues. So I would be thinking like that. And as far as whether surgery might be necessary, I think that all depends. I think all of these other things need to be evaluated first. Also, natural anti-inflammatories. There's Designs for Health has inflammatone. The Thorn has curcumin, phytosome, which is a high dose curcumin. I think that those should always be tried first. And then I think that a surgery decision always needs to be done after all of these things are tried for probably 6 months or so. And then, of course, it depends on the level of disability as to whether a person would entertain surgery for OA.
Okay.
Is that helpful?
Very.
I'm going to just say
I,
one
I
thing.
tried to write down everything that you were saying, all the
Yeah,
supplements.
PT. Um, Margie, you talk and I'll type in the chat for her.
Okay, great. I'm just going to add myself here to this conversation. Yes, I totally agree with Dr. Millman said, but physical therapy is really important. And not all physical therapy is the same, because sometimes someone said, oh, well, the therapist didn't help me. But you really want someone in this situation who works with orthopedics, who has a background in orthopedics. So when you call up, you can ask for that. People, and there's even a specialist, not that everybody has to have this, but it's called the orthopedic clinical specialist. So you can always say, is anybody an orthopedic clinical specialist? It's an actual certification that they've gotten from the American Physical Therapy Association. And you want them to spend time with you. You want them to really evaluate and see what's going on. And the other thing that I've seen so much is so often when you have arthritis and you have pain, you tend to not do things because of the pain. And so your knee gets weak. So by just strengthening the knee, that takes so much force away from the joint. But on the other hand, you see how it works. If it doesn't work, then I am a big believer in going the next step, doing all the things that Dr. Millman said first. I love everything she said, and the PRPs. But if it doesn't work, you certainly don't want to be disabled. You want to enjoy your life. So, then that's when the surgery is if you've exhausted everything else. But make sure to get a really good physical therapist that your insurance covers, that has that specialty. And just by calling the different facilities, that's what I've found.
Yes. Okay.
Okay, good
Thank
luck to
you.
you.
Thank
You're
you very
welcome.
much.
Okay, let's see who's next. Let's see. Is that
All right, Sheena?
Sheena?
Hi, thank you. So how would you coach somebody who has, now this is in Canada, so the units are different, but a CTX of 863, it's in nanograms per liter, and I believe in the States it's picograms per milliliter, is that correct?
I'm
CTX?
I'm 95% sure that it's picograms per mil.
So I think the conversion is 1-to-1 then,
And I think
because it,
nanograms per liter is the same thing as picograms
right,
per mil.
right.
Yeah,
So
I think so.
863
So
with,
generalize that for me a little bit.
so with a T-score in the L spine of -2.7, and at the hip is more in the osteopenic range. The total hip is -1.4, femoral neck is -1.8, and trochanter is -1.3. So about 5 years post-menopause on transdermal estrogen and oral progesterone, and very good nutrition, non-smoker, non-alcoholic. So what direction would you coach them with that?
That's a lot of specific medical
Yeah.
that's a lot of specifics there.
Just to give you some background.
I understand the background, but I think you're
It's
clearly
hard to just
asking for
take the
medical
860.
advice here. Oh gosh. Okay.
Okay, could I say, would somebody who has a CTX in that range
Well,
be,
so here's what I would do. Okay, I would say, if you had a patient who had a CTX in the high 800s, and that whole thing about the discussion about the conversion units, that's all general. That's not specific to you. So you still could ask that. And the person has, a very mild osteoporosis in the spine and osteopenia in the hip. She's on BHRT. Then, what kind of direction would you go in? That's probably what I would say. The first thing that I would do would be to look at that person's estradiol levels. I would look at sensitive estradiol levels and see whether she is hitting a target goal for bone support, because estradiol needs to be at least 15, and I don't know the units. But 15 is in my lab tool. Margie, do you know the link to my lab tool? It's RR underscore
Yeah,
lab.
I'll put, wait, right. Yeah, I'll put everything in the I'll put all the links actually right now in the
So the estradiol needs to at least be 15. And I would think that at 865, estradiol is not suppressing the CTX enough, is my suspicion. So my suspicion is that estradiol is not at target. And so I would want to probably see that woman's estradiol target around 30 to 40. And then I would think that that is going to suppress the CTX better. Now that being said, there could be all kinds of other root cause factors that we talk about that could be going on here that are complicating things. So the absolutely the biggest thing to rule out here is hyperparathyroidism, because that if you do like everything right and you've got a little parathyroid nodule, your CTX can be sky high, like high 800s is sky high CTXs. But with you can be doing everything right, and if you have a parathyroid nodule, you will see this. And then you can also look at the 24-hour urinary calcium, because if the CTX is this high, and again, if there's a parathyroid nodule, you'll see it spilling into the urine. So you'll see like a 24-hour urine calcium that's over 300 or something like that. But there could also be gut causes or inflammation causes or other stuff going on. But those would be my two biggest like suspicions of a very high CTX: low estradiol, it's not at target, and hyperparathyroidism. And one of the things that you can do to kind of like be suspicious or not suspicious of hyperparathyroidism is you should never see a calcium 10 or above. And if you do, then it has to be followed. And a PTH should be like in the 30 range. If your serum calcium is 10, PTH should be in the 30. If PTH is in the 50s and you have a 10, then you have suspicion. And you can use Diva Boone's calculator to figure that out. I've just used her calculator so many times now that I kind of know how much the PTH should be suppressed with a certain serum calcium level. But so that was kind of long and involved, but I think that hope that was helpful.
Yeah, thank you. It seems like the PTH is okay, although it has fluctuated, but it seems to be okay.
Yeah, I would take your numbers and go into the Diva Boone calculator and just search on Diva Boone parathyroid calculator, and the site will come up. And if a serum calcium, and also you also look at 24-hour urine calcium too, because there could be a renal leak.
Right, great. Thank you so much.
I just want to add something.
You're welcome. Yeah.
Around 20 people each summit found out they had hyperparathyroidism and they needed surgery. And, they didn't know prior to checking their calcium value. So it's something that we really need to pay attention to. So thank you.
So I just wanted to clarify, if there is a renal leak, would that implicate a parathyroid, like a possible parathyroid tumor?
Yeah, they go along hand in hand, but you could have a renal leak without having a parathyroid tumor. So that would be that you have a 24-hour urine calcium that's over 300. And that could be from metabolic acidosis, which is the most common reason. But it could also be that the kidneys aren't holding on to calcium the way that they should. So that covered a lot of material. I hope that I didn't overwhelm anyone by kind of going into all of that. But this is the way that you have to think, is that you have to think of it all at the same time. Like, Like here is a person who has relatively mild bone disease on BHRT with a really pretty high CTX. So anything over 400, you're losing bone. It's likely in that you have got to stop that.
Dr. Miller, you want to just mention, because a lot of people, that's not a test typically ordered. That's something you and I think is absolutely essential. But you want to just spend a minute telling everyone why that is so essential? Because,
Yeah. Yeah,
really,
absolutely. So CTX is the same thing as C-telopeptide, and it measures the activity of the osteoclasts. And these are the little demolition workers they're resorbing bone because they're going out there and they're taking out the little microfractures, the bone that's damaged, and that's a natural part of remodeling. And then the osteoblasts come in and fill in the cavity with new bone, and the bone formation marker that we look at there is P1NP, and it's intact type 1 propeptide. No, it's intact propeptide of type 1 collagen. And so we look at both, and they need to be somewhat balanced. You do not want to see optimal CTX levels are 250 to 350, and anything over 400, you're losing bone. You've got to stop that. You've got to stabilize CTX.
thank you.
And it can also point to the root cause factors too. Like there aren't that many things that will cause decreased bone formation, but there are a lot of things that will increase bone breakdown. So you got to go through that whole list. It's like one of the first things that we do in the course is we go through, okay, this is, these are the factors that break down bone. These are the factors that don't let bone build up fast enough. So if you have a high CTX and your P1NP is appropriate and within 1/10 of the CTX, you really need to focus on bone breakdown. But anytime you see a CTX over 400, that's like, you got to figure that out.
And the good news, there's really good news here though, because you can monitor and you can figure out your root causes and then people get better. So it's a real positive by doing these tests, right? We've both seen that people are able to figure it out, their bones get better and everything else gets better. Okay, so we'll keep going.
Yeah, I have a huge success in reducing CTX and increasing P1NPs and having increases in DEXAs, and in it not only in not only in my practice, but now I'm really seeing successes in the program too, where people are coming back and saying my CTX was 750 and it's now 350.
And things improve, so it's
And my DEXAs are better. So it's really important to do this. Hi,
Okay.
Donna, you're next.
Okay.
Okay, hi. This might be a jumping off from what you were just talking about, but I want to ask about how should I put this? If there's like less hope for a patient with rheumatoid arthritis. For example, this patient has had rheumatoid arthritis for almost 2 decades, very well managed nutrition, exercise, in recent years, meds. And in all those years, nobody had ever mentioned anything about that. It was a higher risk for osteoporosis. So recently it was a big surprise for them. And so this is a person who does not want to take those toxic meds on top of the other meds they're already, having to take. And so wondering, like, just in a general sense, like when they went for the DEXA scan, it was like a separate question on the questionnaire. That was a surprise to see. It wasn't just like, do you have diabetes, heart disease, whatever. It's like, RA, surprise. So then does it mean that like there's no hope? Number two, like when the person goes to their rheumatologist, who's a functional medicine doctor, like what are some strategies for things, like the obvious things are already happening, working with a physical therapist and stuff like that, trying to, get more calcium, although without eating dairy, that's a rough ride. But also like wondering if there are any like different, not the CTX test, which they haven't had, but like other tests that might reveal more things that could be worked on from a functional perspective, in terms of upping the ante.
Well, I would say from that diagnosis perspective, I mean, the two things that put a person with inflammatory arthritis more at risk is the inflammation. So, all of those, highly sensitive CRP would be really important for that to be completely optimized at less than 1. The rheumatoid arthritis factor should be normal. The anti-CCP antibody should be normal, and really make sure that that autoimmune disease is completely in check. And then the second thing that puts a person with inflammatory arthritis at extra risk is the use of prednisone. So if that is not in the equation, then that is great. But maybe years of being on 5 milligrams of prednisone in the past could have made a difference as well. But those are the two reasons why a person with inflammatory arthritis has an increased risk. So then I also think that not only all the parameters of inflammatory arthritis should be completely optimized, and a SED rate too. A SED rate would be, you want that like 5, like as low as it can go. And then looking at the CTX and P1NP and seeing how they're all relating, but the inflammatory markers have got to come down, and those things, and then everything else, right? And then your I can say a little bit about getting calcium. So my rule of thumb is that a person should be getting 800 milligrams to 1,000 milligrams of calcium from their diet and supplements, and I don't recommend any more than that because of this relationship with vascular calcification. So you don't want too much calcium in your body. You want to have enough vitamin K. You want to have enough magnesium to make sure that that's a synergistic relationship, and that those minerals are well supported. And usually at least you want calcium to magnesium, something like calcium 2 to magnesium 1. So calcium 400, magnesium 200, or magnesium could go even higher. I like a product called Osteoben, Osteoben, and it's got 400 milligrams of calcium dimalate, 400 milligrams of magnesium dimalate. And the very cool thing that it has is genistein. Genistein is a weak phytoestrogen. So if somebody has a history of breast cancer, female cancer, they have to like talk this out with their doctor to make sure that this is something that they can do. But genistein, the data is profound on genistein, how it is good, just as good as Fosamax at reducing CTX, and it also decreases sclerostin like Evenity does. And there is like irrefutable data. Just recently, there was a big meta-analysis that was done with 50 milligrams or more of genistein for at least a year, increasing lumbar spine, increasing total hip, increasing the neck of the hip. So Osteoben for then you get your calcium, you get your magnesium, you get your genistein, but it is a weak phytoestrogen. So potential issues for people who have had a personal history of breast, uterine, or ovarian cancer.
But it's not contraindicated if somebody is taking BHRT. It has nothing.
Absolutely not. But I mean, whether it really adds to BHRT, I'm not really sure. I kind of just like the insurance policy because it's in that product and you need the calcium and magnesium anyway.
And do you think that's like the safest way to take calcium as opposed to some of these like algae-based ones that I read about?
You know, I'm not a big fan of AlgaCal. I just really didn't see. I was measuring urine DPDs at the time, and not really. I don't know. I just was fairly early on in my career when I was using AlgaCal, but I just didn't see enough evidence that it was really it's supposed to increase density, but I didn't really see it. So I usually recommend calcium dimalate and magnesium dimalate, and other forms of magnesium, magnesium glycinate, magnesium L-threonate.
Okay, yeah. I mean,
Genistein isn't, it's my favorite calcium magnesium right now is Osteoben since it's got the genistein in it. And I figure, why not?
no, it sounds really cool. I've been hesitant. This patient has been hesitant to take calcium, although she takes D3 and K and magnesium, just because of the arterial situation.
Oh yeah, yeah. I've done a lot of research on that. And the big thing about it is that and I don't think the studies are ever really done with this synergistic combination of calcium with magnesium. It's always calcium and vitamin D and vitamin K, or it's just vitamin K, and but I mean, you need all of them, right? So I wish there was a study that was out there that looked at calcium, magnesium, vitamin K, and vitamin D all together and looked at these studies, but there aren't.
But what I'm hearing is that you found that this threshold of amount of calcium you've not seen any issues with that.
What I did was I researched the primary data to look at the studies that were evaluating how much calcium you would get in your food and supplements that where that threshold was. So there was a big study that showed that calcium supplements and even getting too much calcium from your food could cause an increased rate of heart attacks and strokes. So that 800 to 1,000 is under that threshold. Because I also think that if you don't take any, if you don't eat dairy and you don't get much calcium from your food and you have a calcium of 8.7, which is like considered malnutrition for calcium, now you're going to push your PTH up and you're going to pull calcium out of your bones. So, we can't look at things from just one angle all the time. We have to look at them from multiple angles. And so that's how I came up with my recommendation, which is 800 to 1,000, including both. And in my program, I have people go on to Chronometer, which is a free application, and they can determine how much calcium is in their food.
What I was going to ask if there was a way to calculate that.
Yeah. Well, thank you for the question. We're going to move on to Marcia.
Well, hi, Dr. Millman. Thank you. My question is, I'm considering taking your class, but I do not have an integrative functional medicine doctor or endocrinologist to work with. And it seems to me that I need somebody to help me with these tests and interpreting them. So my question is that your opinion that I should be with a doctor that would be willing to work with your program?
Well, what I would say is that it would be helpful. I teach you the tests that I recommend, and then I teach you how to do it direct to consumer. So to order it yourself and order it on your own. I have a great clinical assistant, Lauren, in my clinic who can help people she can help you with that kind of thing. I teach you how to interpret the tests in the class. I teach you what my protocols are if those things are abnormal. I allow you to ask questions like we're having right now, where somebody might say, Dr. Millman, I've got 4 overgrowths in my bacteria in my GI map, and then I've got Candida too. What would you do? And I've got an algorithm. Okay, you have Candida, you start with a Candida killing cycle, you do a repopulation cycle, you do a bacterial killing cycle. I tell you what I use in my practice for Candida killing cycles. I tell you what I use for repopulation. I tell you what I do for bacterial killing cycles. And then the stuff is in my favorites in the full script, and so people can just go and order these things and try. And then I say, okay, when would you redo a GI map? How could you figure out whether things are better? I've got a whole digestive systems analysis. I've got like 3 assessments for digestion. And then that kind of leads you also like, do I need digestive enzymes? Do I need hydrochloric acid? What do I need? Right. And so I try to do the best that I can in guiding you along. But I also do think that it is absolutely better to have somebody that you're working with. Um, but I think that what Margie and I have determined is that even if you are working with a functional medicine doctor, that often they don't understand the bone turnover markers. They don't understand how to take a bone turnover marker and how to like kind of incorporate it into an integrated procedure. So I think that I'm definitely bridging the gap in that kind of respect.
So this
And
patient,
if you're in California, we're taking patients.
well, I'm in
Would you say that again?
Virginia, so that isn't going to help.
Humana insurance, correct? No, I have that. No.
Hang on.
Can you hear me?
Yeah, Patricia's iPad needed to be muted.
Okay, I just muted everything. So let's.
Okay, Marcia, you need to come back online.
Okay, can you hear me now?
Yeah.
Okay, sorry. No, I'm in Falls Church, Virginia, and that was one of the questions. I didn't want to waste time on this program.
Yeah.
But that's my sense because this patient is 82 years old. She's got a spinal DEXA of minus 4.7 or 8. And the endocrinologist I know is heading toward for this patient to do an injection of something. And I'm resisting that. And there's this scare of fractures of this patient.
Yeah. So if I had a patient with a negative 4.7 in their spine, I would definitely be recommending Evenity. And I would definitely, whenever I have a patient who I'm recommending a medication for, because negative 4.7 is really severe, I would absolutely want to know their CTX, and Evenity is good because it does hip and spine. And I would definitely have that patient go and get a consultation from Dr. McCormick. Any of you on this call can call Dr. McCormick's office and can get a consultation. Any of you. He works virtually across the country. I talk about him all the time. He's absolutely brilliant. Margie loves him. I refer to him. I will refer to him all day long.
So the Dr. McCormick, I think he was on Margie's program. Is he the one that
said
medicine is absolutely necessary? I mean, that's what I heard him saying.
I'm not giving you medical advice, but I'm telling you that if I had a patient with a negative 4.7, I would be highly recommending some kind of intervention. And I think the only thing that I would recommend in such a severe case would be Evenity. And I would be really worried about fractures. I would be really worried.
I want to just add something to this because so often people are like, oh, no, 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 I won't take medication. Under no circumstances, it's toxic, it's this. And then they fall, and then something like, with that kind of number, they have a fracture, they're in the nursing home, their life is really changed. And so what I've learned so much from Dr. McCormick, and I'll get his number actually and put it in there, is that you can use it to buy time, to get over the gap while you're figuring out what's going on. So it's not that you're not doing natural things, you're using this just so that you don't fall and have a fracture, just so you gain some bone, and then you can do all the other important things. So it's not to go on forever, but it's to go on right now so nothing bad happens to you. Because too often people, I just have seen it where people feel so strongly. And as both Dr. Millman and I are as integrative as you can possibly get. But this is one situation where it really does help. There is a place, and we both have seen it, that when people do the combination, so we're not, so anyway, I'll put his, and he's just the nicest.
Thank you very much. Thank you both. That's helpful.
Okay. I'll put it in the chat. Okay, next. Do you want me to keep calling people? I see.
Yeah.
Okay, let's see. I see Barbara. Let's go to Barbara. Okay, hang on. Barbara. Okay, Barbara's up.
Oh, there's one more thing.
Yeah.
Sorry, it's left my mind. Okay.
Okay, Barbara, you're up.
All right.
Another pink.
Yeah.
We're pink today.
I just have a quick question, and that is, what would be the appropriate amount of vitamin D for someone with a vitamin D lab level of 37?
Okay, so this is complicated because vitamin D, the amount of vitamin D that you need is dependent on your weight, which is the amount of fat you have. It's dependent on your skin color. It's especially dependent on season. So it will vary from season to season. For a white person who is, so because of a light skin color, we make vitamin D easily from our skin, so we need less than if somebody is an African American, then they need more because they're not going to make as much from their skin. Okay, so if someone is thin, then they don't need as much because because vitamin D gets stored in our fat cells. So a thinner woman doesn't need as much as I need. I have more fat cells, so my vitamin D gets stored in the fat, and I need more. So and then it's winter now, so we need more in the winter and we need less in the summer. So for a white woman who is relatively thin in the winter, I would say somewhere between 3 and 5,000 IUs, just based on, just kind of a guess. And then if my patient's level was 30, I would actually prefer that patient's level is a little bit higher. I know that I think that Diva Boone disagrees with me in this case. I think the parathyroid people really disagree with me as far as vitamin D goes, but I like it to be a little bit more like 45, 50, and absolutely not higher than 80, but I don't think she likes it even higher than 45 or so. So if a person is already taking 3,000 and is at 30, I'd have them take 5,000.
Okay, that was very helpful. Thank you.
Welcome. You're welcome. Amy?
Oh, hey, Dr. Millman, it's good to see you.
Oh, hi. You're not Amy.
I don't know why. I'm using a different computer and I don't know what happened, but it's my middle name. So my question is,
you're using Amy's computer.
my question is, if you had a patient on hormones with a CTX of 300 and a P1NP of 40, would you increase the estradiol if the Dutch estradiol was in the middle of the purple range?
Well, yeah, I mean, you've been my student for a long time. So you know the optimal range for CTX, don't you?
Yeah, yes.
What is it? Let's quiz you.
250 to 350 roughly.
Perfect. You're perfectly. She's a perfect student. Okay. So the CTX is optimal.
Right. And
P1P is P1P appropriate or inappropriate?
yes.
It's appropriate,
Right.
right? Okay. So the bone turnover markers look wonderful, right?
Correct. Right.
Okay, then so sometimes you can get kind of fooled by the Dutch where it looks like it's in the middle of the postmenopausal range, and you remember, my targets,
Right.
aggressive targets versus conservative targets. If a woman is older than 60 or greater than 10 years after their final menstrual period, when they initiate hormones, then they're in a conservative target. That conservative target would be something like 20 to 35. So probably what I would do is to do a sensitive estradiol in the blood and look at what that is. But I'm kind of thinking that CTX is suppressed enough from the estradiol, and I would probably be happy with that level. But if it were 15 or if it were 11 in the blood, and remember you have to get a sensitive estradiol LCMS, right? Because we're looking for the low levels of estradiol. So if it was 10 or 12 or 15, I probably would want to get it up to 20, 25, 30.
Okay.
And then likely the CTX wouldn't go any further down.
Okay. Yeah, because you had the optimal and the Dutch was, I think, 0.7 and 1.5 or so.
Right, you're kind of trying to hit that gap, right?
Yes.
Yeah,
I
the
still
gap.
need to hit that gap, even though the CTX is good.
No, no. No, I would just be confirming, I would be confirming the estradiol level in the blood instead of
okay.
completely going, you see what I'm saying, right?
Okay.
So I would want the sensitive estradiol in the blood. Sorry, I didn't make that clear. Sensitive estradiol in the blood, I would want somewhere around at least 20 to 35.
Okay. Okay. Great. Thank you so much.
You're welcome.
Wait, before we go on, Dr. Millman, why don't you, in an hour, why don't you just tell people what your course is just for a minute? Because I think
okay.
you know what I'm saying? Because some people are hopping off, so I just want you to just
Okay,
help
sure.
people what it is just before we
Yeah,
go.
so Margie and I co-teach and co-founded this course. It's called Restore and Rebuild 100 Days to Healthier Bones. And it is 14 weeks of content, and I'm sorry, it's 14 weeks long. It's 10 weeks worth of content, and it's 4 weeks worth of integration weeks where you have the whole week off. And there's pre-recorded trainings that come in on a Saturday, and then we have live Q&As that next Thursday. And that's during the 10 weeks when we're not in integration. And we go through basically the framework that I have that we've been talking through here, and this framework that I use in practice and to identify your root cause factors. So we're looking at identifying through symptom assessment, and there's lots of worksheets and there's lots of resources in that in that from that respect. We're looking at identifying through lab tests. So I teach you how to order lab tests if you don't have a functional medicine doctor, or I give you the codes if you do, and then give you interpretation guidelines. So, what just as I was doing with the net, what are we, what's optimal, what's not optimal, what do you do in this situation? And then protocols for if something is not optimal, what do you do? And then how do you retest to figure out whether you've had success, whether you need to veer off course, something like that. So I think it's been very successful. We've had lots of great reviews. I'm sure we have a few people on that are, I know Kathy Beck is here, Annette is here. There may be, I know Kristen is here. If anybody wants to come on and talk about how it helped them, I don't know if any, poor Kathy Beck, we ask her every time, but
I can come on.
okay.
Is that Kathy? Who is it? Like, I can't see.
This is Jeanette. Yeah, you can't see me.
Jeanette.
Yeah.
Oh, okay. Do you want to show your video or you just want to come on
I
speaker?
can. Yeah, I can do that. I'm in my kitchen. I may look like hell, but
Oh,
anyway.
that's okay. We're okay with that. Okay. Since you're in a blue shirt, Jeanette? Okay, I see you.
That's me.
Okay.
I just wanted to say a few good words about it because I mean, and I did not have a lot of help from many medical professionals. But I do have a little bit of a background in biomedical science, so that helped. But the program is fabulous. I mean, they lead you through exactly what you need to do. They give you lots and lots of support. Just wanted to put my 2 cents in and say, if you're thinking about it, you should do it. So
thank you. That's very kind of you. Appreciate it.
I just want to say something also. So years ago, it started that so Dr. Millman was on all my summits, and we've known each other for quite a long time. And everybody, I think knowledge is power. And both Dr. Millman and I believe that. And a lot of times, people learn things at the summit, but yet then they don't have the practitioners to help them. So it's frustrating. So that's when everyone's like, well, Dr. Millman, can you help me? But unfortunately, she's one person and in California. And so we wanted to clone her. And then I said, well, maybe Dr. Millman, you could start a course, to help people so you could work with, a lot of people. And that's how it started. But it way surpassed my expectations, I have to say, in terms of people really being able to figure out. And I've gone to, I teach 2 of the classes, but I've also gone to the whole course. So I've learned so much myself. But I think the people are so knowledgeable that their doctors are like always amazed and they know the questions to ask. And when you're knowledgeable, it changes your entire medical care. And that's sort of my premise as well, because then you know what to ask. You're no longer just passive recipient. You're actively participating and things get better and people have done amazing. So it's been such a win-win. And it's, just for those people that it resonates with, I just wanted to let you know about it. And Dr. Millman always gives my people, anyone in my community, $100 discount. So it's reasonable for what it is. I think it's way less than many programs of a similar quality that you're working with a physician, and talking to a physician and really getting amazing handouts that help you. Anyway, all right. So that's anything else you want to say before we continue the question?
I guess, someone was saying that she's going to not be available for 10 weeks. And so we run this course twice a year. So the next one's starting March 1st. So it's a pretty quick turnaround, but there's still our spots available. You can still sign up. And another thing that's happened too, that like quite a few people have kind of said, I got started late and I didn't get testing done when I felt like I needed to get it done. And I felt like I was behind all the time. And then they just they end up signing up as an alumni, which is like 247 instead of 797. So you get a big discount for being an alumni. And then they just do it over again. And then they kind of have more time to get through it. And then the other thing too is that during the Q&As, if you feel like you're behind, then I'm always answering questions from earlier modules. So it's not as if you have to be absolutely, of course it's better to be tracking all the way through. And some people think that they really need to go through it twice or even, I don't know, Kathy Beck is probably gone. Kathy Beck, you're on your fourth time, huh?
Oh, Kathy's still here?
I saw her in the chat
earlier. I think she had to go. Yeah.
But so, and then other people will just say, it's not that I need to go through the material again, but like I'm always updating things, I'm going to talk about a new peptide that, I just learned about that cures leaky gut. I'm going to talk about, some new products that I've learned about. I'm going to talk about some human milk oligosaccharide prebiotics that come from, they're fermented off of dairy, but they're but they are prebiotics that are quite unique in the industry, that from two Cornell scientists. So I'm always looking for new things, and I'm always incorporating them into the class. So things are always evolving and changing in medicine, right? And especially in functional medicine. And I'm always learning. So people will stay with us, and the community is outstanding. I mean, I mean, the level of support between the people in the class is incredible, like.
That's what I love. I'm just such a community person, and it's hard to do this yourself. So when you have the support of everybody, it really makes a difference. All right, I guess we're gonna ready. We'll go on to because we want to finish up these questions.
Yeah, the for Richard, yeah, you have to pay every year for the alumni for the updates.
Okay, so you ready? I guess Cynthia's next. Is that right?
I'm ready.
Okay, Cynthia, you are on. Hi. Cynthia Henry.
Okay, that's me.
That's you. Okay.
Thank you so much, Dr. Millman, for your time. Just
You're
wanted to,
welcome.
I've so appreciated. I have a fairly simple question. I believe it may have been last year's summit, but Mira and Jason Kelton,
Yeah.
they've got a whole book and they talk about micronutrient competition.
Yeah.
So I'm just interested to know if you've done any research on that and if you recommend to your patients, do they need to separate, for example, their calcium and their vitamin D for the best absorption?
Right. Hold on, I'm just finishing a chat text. Okay, so this is what I get this question all the time. And I've really thought about it. I know Jason and Mira, and I have known them for about as long as I've known Margie. And I have certain patients who want to be on their products, NutriEssence, which like splits up the nutrients into AM and PM, and deals with all that micronutrient competition. So this is what, if you don't use NutriEssence, things get really complicated really fast. And even if you do use NutriEssence, things get complicated really fast, right? Because if you want to put something else in, then, I literally have a patient who is, she was like, she swears by them, and I really admire and respect them. And she literally has a timer on her phone as to when she has to take what thing. And so this is the way that I was taught a long time ago. Is, let's say that the efficiency of taking that one particular thing goes down by 25%. And so it's now 75% efficient instead of taking it in another way that would have made it 100% efficient. I'm just throwing numbers out there. Then what if you don't take it? What if the schedule is so impractical that you forget this and you forget that? The efficiency is zero, right? So so I have always tried to make things like, there are certain things that absolutely have got to be taken on their own. The indiscriminate binders like charcoal and clay, they will bind your nutrition, your supplements, your medication, your food. There are certain things they have to be taken away from other things. And those are the only things that I recommend get taken like that. And then the other thing that I can say is that I do micronutrient testing in my practice all the time. And when I tell people to take their calcium and magnesium and et cetera, et cetera, et cetera, not worrying about micronutrient competition. I look at their micronutrient levels and they look good. Their vitamin D looks good. Their calcium looks good. Now, if somebody's calcium is 8.7, I can't get it up, then what's going on? Usually it's their gut, they had gastric bypass surgery or something like that. But somebody's vitamin D doesn't go up. Why? But I have never found it to be that crucial, and I just find it to be super impractical.
Wonderful. Thank you. I've pondered that and wondered. Every single supplement I see on Fullscript has them combined. And I'm wondering, why would it be that way? I'm sure these other people are doing research as well. And I was just a little baffled at that. So thank you. I appreciate that.
Yeah, I mean, I would have to use that as evidence as well, right? Yeah,
Okay.
you don't think these supplement companies are trying to do the very best that they can for the people who are taking their supplements? And so I would use that as evidence as well.
Okay. Thank you.
Yes, Annie, I'm in Los Gatos.
Okay, Rosalie, you're next.
Well, actually, my question was just answered, but the same hold true like for the fat soluble vitamins. Is it all right to take them all at the same time?
Yeah, I don't separate them. Yeah.
Great. Thank you.
You're welcome. Cynthia. Oh, just for everybody to know, I'm in the San Francisco Bay Area. I'm in Los Gatos, so that's right around the corner from San Jose. I live in Los Gatos. I live in Cupertino. Not everybody with cats have to live in Los Gatos. All right, Cynthia. Cynthia Henry. Oh no, you guys put Lori and Cynthia. Put your hands down, please, or put your hands down. Yeah. All right, Kathy.
I think we did Kathy, right? Weren't you on,
Nope.
Kathy? Wait,
No.
like we already had Kathy, didn't we?
No, that Kathy.
Oh,
No.
Kathy, no, there you are. I got you. Okay.
We both had a different Kathy.
Okay, so I've been trying the best way to word this for the last hour in my head, but I think we kind of all know that. So estrogen is good for the bones. It's good to lower CTX. But I have had this person. Okay.
You're doing good. You're doing good.
Okay. I've heard from numerous doctors that they will not do hormone replacement for an osteoporotic woman 10 years past menopause because the benefits of the estrogen, not only for bones, but the benefits in terms of cardiac and brain health, which I need someone to sort of clue me in on what is when they say brain health. But anyway, so the cardiac risk and the risk of having a negative response after, if you're more than 10 years out, actually increases. What is your point of view on that? What have you found with patients that maybe are more than 10 years out and start hormone replacement?
Right. Well, I mean, this is a really long discussion, and I'll try to condense it as much as I can. I certainly cannot cover all of it. So, let's see. So, number one, there's a breast cancer risk tool that has been. It's at the National Institute of Health that I always run everybody through, and I want to know what category of risk they're in from a breast cancer perspective. So that includes their family history, whether they have a breast biopsy, etc. So you have to take into account what is that individual person's risk. I also put them through a cardiovascular risk calculator and see at what level their risk is from cardiovascular risk. The National Society for Menopause and and I think it's also National Endocrine Society. They both have. Thank you, Kristen. Kristen. And they there are risk thresholds by which they say if your breast cancer risk is between this and this, I think it's 5 and 10%. I can't quite remember right now. 5 and 10%, then that person could be a candidate for BHRT. If this person's cardiovascular risk is between this and this, then they could be a candidate. So that's the first thing that I do is look at that, because that's individual risk. Now, if you look at overall risk, yes, it is true. They have found in the ELITE study, they found that a woman who was there was a late group and an early group. The late group was older than 60 or greater than 6 years after the final menstrual period. Early group was younger than 60, less than 6 years after final menstrual period. And there was, in the early group, there was a decrease in cardiovascular progression. And in the late group, there was an increase, slight increase in cardiovascular progression. In the Finnish study, they did, instead of doing, and they used in the ELITE study an endpoint called CIMT, carotid intimal medial thickness. And so they found a slight increase in CIMT. In the Finnish study, they actually used real endpoints, which was cardiovascular mortality and events. And in the Finnish study, they did the same thing. This is called the timing hypothesis, whether it's greater than 10 years after the final menstrual period. They found that it didn't matter. Like there was no increased progression, there was no increased mortality risk, etc. There's been a huge, big Medicare study that has come out since then. It actually shows that in every single thing that they have actually looked at for estrogen, estrogen reduces the risk of colon cancer, breast cancer, uterine cancer, cardiovascular disease, AFib, and all of these women are Medicare. And so all of them are over 65, and most of them have been treated for more than 10 years. And so there are a lot of mostly I would say that traditional OB-GYNs are very hesitant about treating a woman who is more than 10 years after the final menstrual period. But functional medicine doctors who do BHRT are finding that the evidence is maybe there's a small amount of risk. We try to do the best job we can in educating our patients on what that risk is. Nobody can say that the risk for BHRT is zero. We can't. We don't know, right? There's just not enough evidence to say that. But then we have to look at the benefits. All estradiol patches are FDA approved for the prevention of fractures. All. So that's a benefit. Yeah. We've talked about for quite some time right now where estrogen is anti-resorptive. It stops bone breakdown. When you start to go into menopause and lose estrogen, you start to break down bone very quickly because of the loss of estrogen. Well, BHRT stops that. Now, that being said, BHRT has to be a long game for osteoporosis, right? Once you commit to it, it needs to be something that you're going to commit to long term. And I have very few people who have any side effects or any bleeding. I just, most women feel better. I don't know that I've had any woman on BHRT who's had a heart attack or stroke right after going on BHRT. So, and then, the other benefits are that, your skin is more elastic and you might feel stronger. And, we don't just do estradiol, right? We do, bones are better with estrogen, bones are better with estrogen and progesterone than with estrogen by itself. And bones are better with estrogen, progesterone, and testosterone than estrogen and progesterone by themselves. So we do a combination, and the benefits to all of those things go way beyond the bones. And then so what is another benefit? Maybe you don't have, maybe if you've got kind of, there was one person who was talking about a CTX in the 800s, and let's just say that person's not on BHRT. She's uh, got mild osteoporosis and osteopenia, and her CTX is high. Then that person doesn't have to go on bone medications, so that's a benefit too. So you
I'm sorry,
have to,
can you
you
just, can you
have
just,
to,
can you
you
just
have to
repeat that
weigh
very
the
last thing you
benefits and the
said?
risks.
Yeah. Okay. Okay.
All right, you'll get the replay if you missed any of it. Don't
Okay.
worry.
So the point of it is that this decision is up to you. What you have to do is find somebody who is sufficiently educated to educate you, and for you to make the decision that is the best decision for you possible. And you will be able to find a provider out there who will prescribe it for you if that's how you want to move forward. I'm convinced of that. I mean, any of you who are looking for a functional medicine doctor, you can look at for the Institute for Functional Medicine, and probably there are. I've trained under IFM. I've trained under A4M, which is the American Academy of Anti-Aging Medicine. They do a lot of BHRT. You can look maybe A4M has some practitioners. I've even heard of recently some patients of mine have been like I've been using like national firms that do BHRT like MIDI Health, and I absolutely in the course really go through the data on BHRT, and it's like almost a full consent process, just so that everybody knows. They want to, if you need to know the data and you don't have a resource for how to learn about BHRT, take my course.
Thank you.
I hope I didn't overwhelm you.
Okay, Lauren.
No, I mean, right. No, the good news is this is a possibility, but it's certainly not essential. And I think the knowledge is power, and then people can have the ability to make the knowledge. And if you just go onto the Institute of Functional Medicine, find a practitioner, you'll get I can put it in the chat too if you want. Okay,
Yeah.
let's see. Is Nicole next? Is that where we're at? Let's see. Yeah, okay, Nicole. All right, you're up, Nicole.
You're muted.
Muted.
Mute. Thank you so much. Well, mine is going to be a little different because I really feel like this is a really deep dive for me. It's like my mind is blown with all of these words. It's a little bit over my head. This has been some educational journey for me. I mean, I was told about osteopenia that I had it years ago, and I guess I was the ostrich, with my head in the sand, figuring, okay, I'll worry about it when I'm like 90. Well, I guess 2 years ago, I was going for a foot surgery at the hospital for special services, and they said, well, you have osteoporosis, so this changes the whole deal. It changed the whole surgery. I didn't go through with the surgery because it changed it in a terrible way. But from there, they sent me to their bone specialist. I don't know the formal name. And she gave me a list of drugs that I could take and told me, just don't fall. So I said to myself, and I'm a holistic kind of person. I've been in beauty and wellness all my life. I said, there's got to be a better way. And I found this Dr. Lawrence Fishman and started doing yoga for osteoporosis. And I found a yoga therapist who turned me on to an integrative doctor like yourself and Margie Bissinger and her community. Thank you for that 20% off from Fullscript, Margie. I just want to say you're right when I was saying these supplements are, because everything is costly, and an integrative holistic doctor, of course, didn't take any kind of insurance. And when Margie wanted to offer that to her community, I was so happy. Which brings me if that saying is true, when the student is ready, the teacher appears, maybe I'm ready for this deeper dive. I probably feel like not really to your next course, because it's this is my feeling. My feeling is I want to thank you for this whole comprehensive education. But I don't feel, I feel you could find a doctor or another holistic integrative doctor, but it's with their point of view, not actually yours, and it just won't translate the same. And I'm worried that so it's maybe $800 to start or 700. And then I'm retired, so I have Medicare and a secondary. And then there's some things, the supplements, and then additional things. But then I appreciate that. I think I'd be one of those people that wouldn't be able to keep up, because um you still couldn't be my doctor. Like if you could have me as a patient, I would be all in, and I'm ready to be all in, because I think I've changed the diet. I mean, even just giving up gluten and finding out all these things has been quite a journey. It's very different. And I do a lot of yoga for osteoporosis. I'm dying to get very close to you, Margie, because I'm in Dingman's Ferry and you're in Morristown. You're not that far. I'm thinking that I just want to reach out to you, because I want to take that deeper dive, but I guess it's the fear that I know you'll explain everything and how to figure out what's right and what's wrong. But I think that, like you said, I do think a person is going to need more. They're going to need, like, to be your patient, and I'm not in California. And that's troublesome to me.
Okay, so let me try to interject. I understand where you're coming from.
Okay.
Lots of people are overwhelmed by my stuff because I don't hold back. It's just the way I am. And
you're a doctor. It's
and
fine.
right, and I mean, people are going to be attracted to my style or not my style, right? And that's all okay. But what I will say is that I have heard this over and over and over again from people in the course. In fact, but I've only had one person get like asked for a refund because she was so overwhelmed. Only one person, and I don't even know how many we've had now, Margie. Like, we're into like the 400s now. Only one person asked for a refund because she said that she was so overwhelmed. And the thing of it is that this is what I tell people all the time in the class to do, is to prioritize, right? So if you're going to prioritize, you get a CTX, you get a P1NP, you see where you're at. If your CTX is high, you got to find out why. I give you a little list, okay? As you go through the class, you're like, oh, I definitely have some gut stuff. Oh, I definitely have some blood sugar stuff. Oh, I don't think I have any inflammation. I don't really feel inflamed. Or I don't have blood sugar stuff, but I definitely have gut stuff, right? And then you just kind of focus in that area and focus on it for 3 or 4 months and then recheck your CTX. And even if you can get that much done, it's something. And even if you understand the framework, oh, these are all the things that I can really think about. And then when I find a functional medicine doctor, then I'm like totally like, I mean, people in my class are teaching their functional medicine doctors how to deal with CTX and P1NP, and they're teaching their endocrinologists and their rheumatologists. Like, they're saying, well, I need a CTX and a P1NP now before I start my medication, then I need it at 3 months. And having that, having that is really, I would say, empowering. And also, there's no big race for doing this unless you have a CTX of 900. If you have a CTX of 900, then don't fall.
You know what? I use the word integrative, but it's functional. And I do have a functional medical doctor who's been taking blood every 4 months for 2 years. I don't think the panel or anything or any of the other tests, we've done, initially I did a saliva, but I think yours is way, way, way more comprehensive. But if I had to guess, and she's very nice, Margie might know her, I don't think it's correct to name names, but she's very nice. But if I had to guess, she would have a different feeling than a different functional doctor. And then you know how that middle class falls through the holes? That
Yeah, and I
person.
mean, I don't really like people to come into my office and say, I want a GI effects and not a GI map, you know. I'm like, well, you know, I kind of like GI maps. Like I'd rather use that than a GI effects, right? And but the GI effects aren't that far away from a GI map. And if you have a functional medicine doctor to help you figure out whether you've got the general concepts are kind of still the same. And what do you think of, and please do not think that I am trying to talk you into this class because
I don't think that. I don't think
okay,
that way.
good.
Like I
Okay,
said to
good.
you, if you were,
Yeah.
But what do you think about the fact that you can, as you go through, I believe in people's instincts and I believe in the innate healing power of the body. And I believe that when people go through the class, certain things are going to resonate with them. And so they're going to go, oh, I know I've got to do that. Oh, I, why don't I try like upping my magnesium and taking some chromium for my blood sugars? Oh, why don't I do a little bit of apple cider vinegar and go for a walk right out? And why don't I try to continuous blood glucose monitor? Right? And if that's all you do in the 14 weeks and you get something out of it, then
Yeah.
the next time you do something else.
Yeah,
I
I
don't
just
know
want
what
to
you were
say
gonna,
something. Can I
yeah,
just
tell me,
begin here?
Margie.
Okay, so overwhelm after the summit and after this, you get bombarded with information, and overwhelm is truly the enemy because people freeze instead of moving forward. There's just too much information, so they say, "No, I'm not doing anything," and that's our enemy. But it's one step at a time. And so you can decide if it doesn't resonate with you, then that's one of the reasons I
No,
had
no, it does resonate, and it wasn't from the summit. It's just the podcast I learned. I just this morning. I didn't see you on the summit, although your name sounds familiar because I've done 2 summits. It was just the podcast,
Oh,
and
that's so cool.
it does resonate. But what I
I'm not
feel
saying
bad about,
onion. It's an onion. You do one layer, and that's
right.
the only way people get better. Like,
I
I've
just
been
don't want to. I just don't want to waste my money, and I don't feel like you're talking me into it. The sad part to me is that I wouldn't be able to be a patient of yours, and I won't gain as much as I. The way you're saying it now is makes me feel a little bit better because from what I after the podcast and I read it and all those things, the graphs and where we should be and how to figure this out and what to order, it seemed this seems a little bit more the way you're explaining is a little bit more casually absorb the info.
And that's how you have to take it. You take one thing, and that's how I've only seen that people get better. You do one thing, you move to the next, what you're comfortable with, to your tolerance. Like some people might just, if they're going to start exercise, put sneakers on and start one thing.
I
And
get that, but I think this is a bit of I think it's a little bit of a I'm not, it's all worth it. I'm just saying, I feel like it's a financial commitment. It's
Yeah,
not $50.
yeah.
Okay, so I want to know that if it's too much for me, maybe I'm not ready this year. My gut says I want to be healthy.
Well, that's why we have both Dr. Millman and I have these free educational things. That's why I do the podcast to give people, and she's giving the tool. So start with the tool, and there's certainly if something doesn't feel comfortable, that's not the point here. But anyway, we're going to move on. But the point is
Okay.
one
Thank
step
you.
at a time. And that's how people get and celebrate. You do one thing. Oh, I've added some more nutrients into my diet. Okay, great. Next thing. So anyway, thank you though for sharing. Okay, let's see. Because we want to get through everybody. We have like 20 minutes. Okay. Am I in the right order that Debbie's next? You have Debbie too? Yeah.
Didn't we have Laura and Diana Orlando before? I saw them.
Let's look. Oh, you know what? Guess I'm looking at the pictures where everybody is. Let's do it.
Laura.
Okay. So, oh, I see. Yeah, there's Lori, Laura, and Diane. Okay, and then so we have a lot of people before Debbie who don't have their video on. I see. All right, we'll get to you. Oh my goodness. Okay. Okay. Huh. That's interesting. Okay, so let's keep moving. And we'll try to make them a little shorter so we get to as many people as possible. Okay.
Did you say Laura?
Yes, Laura, yes.
Okay. Okay. Hey, want to just throw into that your course was fantastic. I get the feeling about there's so much wonderful information. I'm going back now and taking notes on my notes. And it is like that. You just jot down if something rings your chimes, that's me, and you jot down, but you're not going to write everything. It's like you just have to weed out and let things go that aren't really, it's not you. So that was how I did it, and it's been fantastic. So, but I've got a couple of questions, but I'll just go with this one. Is there a formula to figure out, like, if one has taken the Diva Boone calculator for PTH normality, everything seems normal there. Is there a formula for renal leak?
Yeah. So you can get it done through LabCorp or through Quest. And so it's the 24-hour urine calcium. And so there are two different assays. So at LabCorp, I believe that the top end of their range is 250, and at Quest, the top end of their range is 320. I might be wrong about that. So depends on but it just has to be abnormal as far as either LabCorp or Quest. And so it's suspicious if it's over that.
So if you have this person that I know has had that, the 24-hour urine calcium, and it's high. So would just the fact that it's high be the indication? Is that all you need to have to know that that a person has a renal leak?
Well, so the term renal leak is really about when the kidneys are not reabsorbing the calcium, and it can happen from a couple of different causes. And really, the most common cause is when there's metabolic acidosis, and that acidosis means that the pH of the blood, when you do the first morning urine and you do a pH strip to it, that's very acidic, and it reflects that the blood is never acidic. So I'm not going to say that the blood is acidic, but that the body is acidic, and there are a lot of metabolic ways, like when you exercise, lactic acid is acidic, and so those and other metabolic wastes are acidic as well. So what you have to do is get the pH of the urine so that it's more alkaline, and you can do that by using things like potassium bicarb or potassium citrate. And if you remember in the class, I was recommending the optimal from Seeking Health, the optimal electrolytes, and that has 500 milligrams of potassium citrate in it. I think it's citrate, not bicarb. And it's got some other electrolytes in it. I have my patients take that either one or twice a day, and then I have them check their urine pH. And I have to look up I have it written down. Hopefully I can look it up, but the urine pH needs to start, like, let's say that it's like 5.5, which is really acidic, and it starts to go like up into the sixes, which means that it's getting better after the potassium. Then you can recheck the 24-hour urine calcium, and if that is starting to get better, then that means that it is metabolic acidosis. It is like, and then you got to figure out where the toxicity is coming from. That's a little bit deep, right? But just doing the urine pH and doing the electrolytes for a while and doing that little experiment, redoing the 24-hour urine calcium, that's not really that hard to do. You can in the I forget what module it is. I think it's module 3. There's calcium complications. I don't think I go through the urine pH. It's something that I've been having Dr. McCormick teach me how to do. That's why it's in my notes from the last time I talked to him. But I'll be talking about it this time. Are you going to be an alum?
Well, I'm kind of thinking about it. I'm got so much that I have in my notes right now already that I'm working through and, testing and that kind of thing and, changing dietary things. The information on the oxalates was fabulous. That's totally changed. But what if a person's potassium is fine? I mean, is
Oh, you
potassium?
can't, no, you can't go by the potassium in the blood level. You just
Oh, I
can't.
see. Okay.
No, you can't.
Okay.
It's um so I think this is the coupon code for Margie, Happy Bones 25. So there's differences between blood levels of minerals and vitamins and then tissue levels. And then
Right.
and what we're trying to do with the potassium bicarbonate citrate is we're trying to buffer the pH.
Okay. Okay. All right. Well, thank you very much.
You're welcome. Thank you for the kind words.
Sure.
Okay, Diana, Orlando.
Hi, how are you?
Good, thank you.
Great session. I'm enjoying it very much. I wanted to say, I had a recent situation where I had COVID and I was hospitalized. I had a severe chest and lung infection, and I do have severe osteoporosis, but I'm not on any medication. Recently, my hair has started to fall out. I have large clumps of hair falling out. And so, and I'm even shedding, like my pillowcase has hair on it every morning. When I brush or comb my hair, tons of hair comes out. And what I started to do recently is I started taking ancestral supplements from that are grass-fed beef thyroid. And I'm also taking something by Dr. Amy's, which is a hormone fixer. I'm sorry, it's testosterone to boost my testosterone levels. But I don't know what is going on with me. And I'm getting a little concerned. Last I was told that my liver enzymes were a little higher than they should be. My reverse T3 was a little high and they wanted to bring it lower. And also my free T3 needed to be raised higher. But my testosterone wasn't really that high. It was at 16 when they tested it in April
So
of last year.
Diana, this is really, really, I mean, we have to just be really careful about medical advice. There's just too many specific details in the story, and the story is just going on for a while. I think that helping a person with hair falling out, I mean, I think about iron, I think about zinc levels. I worry about hypothyroidisms. Those are really the three biggest ones. And ferritin, which is iron storage, needs to be around 60. If it's high, that's bad. And we know that lots and lots of people actually do lose their hair for quite some time after COVID. And one of the things with COVID is that ferritin, which is the iron storage, it's also when it's high, it's also related to inflammation. And so that often can cause hair to fall out. So I would be if you know, in a patient of mine with hair falling out after COVID, I would be tracking ferritin levels and doing some natural things to reduce ferritin. I think some of the anti-inflammatories like inflammatone, the curcumin, phytosome from Thorn, probably really looking at inflammation and hypothyroidism would be two big concerns.
Okay. Okay. And so you mentioned inflammation, you mentioned inflammasome. Is that one? Supplement?
Inflammatone, it's from Designs for Health. It's an overall natural supplement for inflammation.
Okay. And what was the other one you mentioned? There was another one?
The curcumin phytosome. So that's the curcumin is the extract from turmeric that helps with inflammation.
Okay. Thank you very much. I really appreciate your feedback.
You're welcome. Kristen?
My question is regarding the vitamin K recommendations that you had in the summit talk. Because on your slide, you're saying that it's not necessarily a recommendation for someone on blood thinners or clotting disorders. Is that mostly for the K1 recommendation or even the K2? And how much of a disadvantage would somebody be if like they're not supplementing with K1 because they shouldn't? So.
Right. So vitamin K1 is the one that is processed through the liver more than vitamin K2, either MK4 or MK7. So I would think that there would be a higher risk for extra clotting with K1. Here's what I found though, is that in doing probably another, I don't, in looking at the vitamin K for vascular calcifications, I probably read another 40 papers. The problem is that if you have a clotting disorder, now, so here's the good news. They were looking at vitamin K1, 1 to 10 milligrams. 10 milligrams is a lot of K1. They were looking at MK7. They were looking anywhere from 90 micrograms to 720 micrograms of MK7. That's a lot of MK7. All the safety data was no extra heart attacks or strokes, like just safe. The problems is that the studies have never been done with a person who has a clotting disorder. So can we generalize and say that it is totally safe? That's really the problem. And so that's why it's such a gray zone, right? But I would think, and the other thing that was brought up in the papers was that the mechanism by which clotting and also taking the calcium, the osteocalcin and the GLA matrix protein get carboxylated in order to take the shuttle the calcium into the bones out of the vascular spaces, and they were saying that there are only so many carboxylation sites. So even that there's only so far that you can clot. There's only so far that you can that's another reason why they're considered safe, right? But with someone even being a carrier with a clotting disorder, I can't make a call.
Sure. Okay. Thank you.
And in my own patients too. I mean, I would have to say, let's talk to your hematologist and see what your hematologist says. And I know that most hematologists are just going to say no. And then if it were my patients, I would say, you have to make the decision. It's up to you. You have to take the risk. And I don't know what that risk is because we don't have the exact data that is your situation. Right?
Sure. Yep. Thank you.
Helena?
Hello, can you hear me?
Mm-hmm.
Okay, great. Thank you for all your time today. I appreciate it.
Welcome.
My question is, what does osteocalcin test for exactly? And what does it mean if it's high for postmenopausal women? And how often should it be tested?
So I don't test osteocalcin at all, because it's really, so what osteocalcin does is that it shuttles the calcium from the vascular space into the bones. And a GLA matrix protein does this as well. The really, so the carboxylation and the phosphorylation state of osteocalcin determines whether it's going to be active or not. So it needs to be carboxylated and phosphorylated. And so the research studies are using decarboxylated osteocalcin and dephosphorylated osteocalcin as surrogate
She's
markers.
telling me a lot of stuff. See, this doctor didn't explain this stuff to me.
Yeah. Oh, and we made out of the bread, right?
And could you please mute?
The bread?
Yeah.
Bread is in there.
Mute everyone.
Yeah, yeah, I took it out of that.
It's
Where
Anne's
it was.
iPhone that's coming up.
Okay, unmute again. Helena, let's unmute Helena.
Okay, so in in the studies, they're using dephosphorylated, decarboxylated osteocalcin as a surrogate marker for vitamin K status. Because if there's not enough vitamin K to carboxylate osteocalcin, it'll be decarboxylated. And so I'm not going to run, you can't really even get such a thing from LabCorp. And just looking at osteocalcin by itself really isn't an accurate marker for anything. I know that some doctors are looking at osteocalcin and calling it a bone formation marker, but it is a very tricky one. Like if it's too high, it's not good. If it's too low, it's not good. And it's very tricky. And from my perspective, the studies just show that it depends on the carboxylation status.
So it doesn't need to be retested again. You wouldn't consider it to be one of those tests that would need to be repeated?
I don't test it at all.
Okay.
All right, Debbie, who I called on.
Thank you.
I feel badly. I know okay, you're on,
Okay.
Debbie.
Yes, thank you. Okay, so my question is, does chronic sodium, low sodium, specifically SIADH, if you have that, does that affect bone loss? I'm getting or I'm reading just conflicting information on that. And also, does your sodium level, how high you keep it in the optimal range, does that affect bone loss?
This is way beyond. Yeah, I mean, I have 2 patients with possible SIADH, and I'm just sending them straight to an endocrinologist to make these determinations. But so how much you have sodium, how much sodium is, so with SIADH, there's how much sodium is in the blood, how much sodium is in the urine, right? And that the kidneys can't hold on to the sodium. And
from drinking too much water over years.
Yeah, and so what's happening with the urine electrolytes is really important. But I think that SIADH also has a calcium component to it too. So I think there might be 24-hour urine calciums that are high, but really this is a very, very specialized question for a very, very specialized doctor. And I used to be able to handle it when I was just out of residency, but I don't do it enough now. Sorry.
Okay. Do you think the low sodium does affect bone loss though?
I don't think that low sodium I don't I don't know, just because the minerals and the electrolytes are so tightly regulated together that it might be causing changes in magnesium, calcium, zinc, and not only changes in the blood, but changes in the urine. And if the I seem to think that I seem to remember that there's a component of SIADH when there's a high urine calcium, and that is always a problem for the bones. And oh, and high urinary zinc is also a problem for the bones. So the minerals are just so intertwined into all of that, and how the minerals buffer when there's low this and low that, and that is, SIADH is a kidney problem, right? Or maybe it's a brain problem. Could be a brain problem or a kidney problem. It's probably a brain problem. Pituitary. But I mean, my recommendation for any one of my patients is let's just try to treat the SIADH as best as possible. And then really keep an eye on doing some, let's look at the urine calcium, let's look at the urine zinc. Let's make sure they look like they're in a good range.
Okay, thank you.
Okay, Diane? Getting some complicated questions today, Margie.
Yeah, do you want to take two questions for 2 hours? You want to stop in a couple, or you want to just finish?
Yeah, we do, right? How many raised hands do we still have?
I see, I do have an important question though, someone had asked that I do want to answer. We have one, two, I see three people who I see their faces. Hi. And then
well, I can see a lot more because I think I'm looking at 1, 2, 3, 4, 5, 6, 7, 8, 9.
Yeah, no, I think it's
I'm looking at 9 or 10 raised hands.
Yeah, so I think we'll.
Okay, so I'm Diane. You said I was next.
I'll answer your question.
My question is, I've been reading a lot lately about fasting, not only for like 12 to 16 hours, but sometimes three days or 4 days, and all the benefits of it. And I'm wondering if you know of any reason why someone with osteoporosis might not want to do this? Are there any bad side effects, or like I only read about positive effects, but they never talk about if you have osteoporosis?
Well, I probably couldn't answer this, but I don't recommend water fasting in my clinic at all, but I do recommend Prolon, which is a fasting mimicking diet, and Prolon can I guess my problem is that there's protein is really important for the bones and your minerals are really important for the bones. So going on a water fast, I don't think so, but Prolon is a 5-day fasting mimicking diet, and that can decrease inflammation, HSCRP, it can decrease glucose and parameters like that. So I would recommend if somebody wanted to do a fast to do Prolon, and that's Prolon.
Okay, I've heard of that one also.
Yeah, I think.
Okay, thanks.
Water
Okay,
fast.
so here's what I think, because we could go for hours. So I think, right, Dr. Millman, but there is someone who did ask a question. They went to register for your class, and it said if you have cancer, you can't. Can you want to just explain that?
Yeah, yeah.
Or explain any restrictions why people should not come to the class.
I do. So yeah, there's some conditions in which I don't think it's responsible for me to have them in a class setting and then for them to kind of misunderstand that it might not might really not be safe for them. So now I'm never recommending to a person in the class, but my general recommendations always have to be like, tempered and put in their own context with their own medical information from their doctor. But a lot of like boron, that boron in doses over 3 milligrams is estrogenic. Genistein is a phytoestrogen. So if a person has had breast, uterine, or ovarian cancer, then should they be taking boron or genistein? Now, I think that in my patient population, I'm going to have a long discussion with that person. I'm going to want to know how far out they are from their cancer. I want to know, and usually I might say it's okay to be on a weak phytoestrogen for somebody who's been more than 5 years out from their cancer. But this is something that this is all the education needs to be put forth to this person. They need to make their own decision and probably take it to their oncologist and see what their oncologist has to say. But everyone's different, everyone's into their own situation. And I just don't think it's thoughtful or responsible to have people having that kind of, oh, I really don't know about, oh, I really don't know about maca, boron, genistein, just these things that are just even mild phytoestrogens. I don't think there should be this, oh, I don't know what to do with this information now. And I don't want to put anyone at risk.
So if they have questions further than this, should they just call your office if someone has like a specific post-cancer question?
Well, we are allowing people who have had, and I'm not talking about like a skin cancer, like melanoma or, thyroid cancer or, and then hyperparathyroidism, if it's in the past, then that's fine. But if it's active, then I think they're too complicated around calcium and everything. And I'd like them to get their surgery and get everything figured out before they come into the class. But we do allow people to come in as a patient and be in the class at the same time if they've had complicated issues.
Okay. And if there's a question, can they call your office? What's the best thing if someone wants?
Yeah, they can call our office, 408-218-9301.
We are.
And they can talk to Lauren.
Tips. I have a whole bunch of stuff here.
Wait, I may have muted you. I muted everybody because there was noise. Are you unmuted?
Yeah.
Okay. I think
408-218-9301 and talk to Lauren.
so. My thought, and what do you think, Dr. Millman, is if people can write in the chat their questions and we can look at them and maybe you'll come on a podcast or maybe we'll figure out. But I think we've gone over 2 hours. Do you agree with me or what's up to you?
Yeah, no, I agree with you. I feel as though there are a ton of questions in the chat. I don't know if you've seen this. I mean, it's possible that it could take me 2 hours to even answer the questions that are already in the chat.
All right, so you know what we'll do? I'm going to put the view back on. Yeah, we sort of knew, unfortunately, we came today, we would do our best to get to as many people as possible. And for people in my community, you can always, have me, or if you do take the course, and if you have questions for Dr. Millman about the course, could call her office because they'll help you with that. And if you have questions for me and you're part of my community, I can help you with that too, or I can always ask Dr. Millman as well if there's something in particular. But we both, Dr. Millman and I, have learned as practitioners that we have to practice what we preach, and we have to we can only do so much. So we said today.
Yeah, and somebody was recommended that we'd pre-submit questions, which I mean maybe we should do that next time. That's definitely the way that we do it in the course, so that we're filtering out a lot of the kind of the lengthy part of the question that's not really germane to. We distill it down so that it's just a very general question, and we try to get to the heart of it. So that's how the Q&As are run, is pre-submitting questions, and then we almost we last time we always had questions for live questions, so that it's somewhat of a hybrid. So you still get that kind of community feel, but also we're cutting out redundancies and some things are just, some questions are we in the course we like to keep to the course materials. So if somebody is asking about like I'm not trying to point this finger at this person or anything like that, but if somebody's talking about SIADH and it's well beyond the scope of the program, we just that's something that we would just say we have to talk to your doctor about that.
Anyway, but the reason we did it this way was for the interaction, and it's easy it's easier. It does take hours when you we both know that, when you have pre-submitted questions, it takes quite a while to decipher. So Dr. Millman was so kind to come, and so we thought this would be the easiest and most fun way, and you've really answered so many things. So all right, everybody. So are we good? And write it in the chat. I will look at the chat, and I will see if there's something really interesting. I also will try to sometimes I have podcasts on the topics or whatever, but
and absolutely, if people have questions about the class, they should call Lauren at the clinic, because she's very well versed in how the class is run and what they can expect.
Perfect.
And just make sure to tell her that you have the Margie's coupon code.
Right. And we extended it because initially it was expiring today, and we extended it to.
Oh yeah, we extended her coupon code. We extended the early bird. So everything's all the way to February 28th, and we start March 1st. So even if somebody wants to come in late, we'll extend it.
Yeah, and you get you get everything first, and then the live classes are on Thursdays at 6 o'clock Eastern time, 2 o'clock Pacific time. And it's all really fun. I always love it. I love when I come to your class. We have so much fun. Anyway, all right. So I always end the classes by saying, say thank you, Dr. Millman, and thank you so much for taking the time. This was a lot of time, and you answered a lot of people's questions, and we're really grateful for you to share all your brilliance. And I always learn. I always learn from Dr. Millman. I learned so much from you. It's unbelievable. Anyway, so is there a word, Dr. Millman, that we always say a word at the end, but we're going to thank you. And then is there one?
I would love for people to have clarity.
Okay. Clarity. That's so great. I love that. And that's sort of what you teach, clarity. And with clarity comes improvement. And I mean, I just think to make everybody feel good, whatever step you take, if you listen to one thing and, oh, yeah, maybe I'll check that out, or maybe, oh, that's a better way with my vitamin D or my calcium, or, oh, yeah, I'm taking too much calcium. Whatever you gain, it's one step. And honestly, I've been doing this for 25 years. One step in the right direction is amazing, and you have to celebrate, yay, that we and do the next step. So don't undermine everything you're doing, and don't belittle any one positive step, because it really is huge, and that's what gets you on the path. And we've seen so many people on this path, and that's why we do what we do, because, right, Dr. Millman, people get better. And they look back and they think this diagnosis was truly a blessing, because their bones get better, their overall health get better, and they're empowered. They feel empowered in terms of their life. And that's sort of our goals. And I know Dr. Millman does that, fear to empowerment. So, all right. So ready, everybody? We're going to say thank you, Dr. Millman, and clarity. Are we good? Okay, ready? Everybody ready? So unmute everybody. Thank you for coming and hanging out 2 hours. Has everybody got out of this that they feel they can put into their Oh, great. Oh, great. That makes me so happy. All right. Oh, you're getting hearts, Dr. Millman. Do you see all these hearts? Woo.
No, I don't see the hearts.
Okay, let's see.
I
Oh,
dropped in the millmanclinic.com bones testing, and that's an area where if you just drop in your email address and your name, that you'll get access to the interactive testing tool. And that interactive testing tool is really helpful. I've had patients and students like fill that out, and then it gives them an idea of what other testing they can do that's pretty basic, and what the ranges are.
yeah, and go back to the podcast episode too that Dr. Millman did. And so when you get the replay, I'll have the links. I've already sent that to everybody, but I'll have it again for them as well. Because it's a free thing, it's amazing, and it can help you keep track. Gives you also the data, like what are the functional values. So when you look at your labs, you'll know what, so it's really valuable, really huge.
Yeah, you put in your result, you put in your date, and then you look at the ranges that are given there. And then I have an algorithm for whether or not I really developed it for the class for them to understand whether they needed to retest or not. But it kind of gives you an idea, hey, as you can expect, a non-optimal test should be checked more often than an optimal test. So I have a whole algorithm in there about, hey, should you retest this, or should you be happy with this test?
Okay, everybody. So yeah, so definitely check that out. So good. And you'll get the replay of this. So you don't have to memorize any of this. You'll have this. It won't go away. All right. So on the count of three, we're going to say thank you, Dr. Millman. Clarity. Ready? 1, 2, 3. Thank you, Dr.
Thank you, Dr. Millman.
Clarity.
Clarity.
Bye, everybody.
Thank you. Thank you, Margie.
Thank you.
Thank you.
Thank you. Thank you,
Bye.
everybody. Thank you.
Thank you, Margie.
Good to see
Thanks so much.
everybody.
Thank you.
Bye.
Good to see everybody. Bye-bye.
Thank you. Bye.
I'm seeing in the chat, and very cool butterfly background. That is the coolest. Magical person. Love that.